medications are managed for hospice patients can be confusing and sometimes complicated. Today we're clearing up some of the misconceptions about deprescribing for patients at end of life. You're listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer, here with Jerry Finter.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Because we know how busy life can get, Heartbeat is designed to give you helpful information in a bite-sized format. At the Heart of Hospice, we're always looking to connect our listeners with resources and services that can enhance their hospice experience. If your company provides a service for hospice patients or hospice agencies, the Heart of Hospice would love to partner with you to expand your outreach. To discuss customized sponsorship options, send an email to host@theheartofhospice.com. You want your clients to have the best hospice experience possible, and the Heart of Hospice can help you make that happen. Now on to today's episode.
Well, we are talking about deprescribing, which is a term we use. I know I'm not supposed to use the medical terms, medical jargon.
All those big words. We're going to be using some big words this time and some maybe terms that people are not acquainted with. So deprescribing is one.
And there's an easier word to understand, simplifying or reducing the number of medications that a patient is taking. It's one of those hospice myths that have driven us crazy.
Yeah, that's true. It's, people think that when they are on hospice that all their medications are going to be taken away from them. And that's not true.
No, I need my buzzer.
It's wrong.
Right, right. So let's talk about what the reality is of medications. So patients with serious illness often come to us with a lot of medications, a lot, especially if they have been ill with a serious illness for a while. They're either on, second, third, fourth tier medications. They've tried the basic things and eventually those things weren't successful, so they've been placed on other medications, or they have numerous medications for their conditions.
Okay, so let me ask you something. You've been a hospice nurse for a long time. What is the largest number of medications that you've seen one patient prescribed?
Oh, wow. Upwards of 20. Going towards 30.
Oh, wow. That's a lot of pills.
It is.
That's a lot of pills.
Well, because a lot of our patients come to us at end of life where they're being seen by multiple practitioners, multiple specialists, for numerous conditions, heart, kidney, lungs, cancer patients that are really progressed in their illness and have multiple complications related to the treatment or disease progression. And those medications tend to build up.
Okay, so I want to ask you another question, and maybe I'm not trying to lead this to any certain conclusion, but isn't it true to say that sometimes a prescription is given to treat a certain symptom or illness, and then the side effect from that medication causes something else to happen. And so now a prescription is given to actually offset the symptom of the first medication.
Exactly. Right. Yes, that does happen. It's a cascade effect. And what they have to consider is benefit versus burden. Does the patient get more benefit from the medication than they do burden of that side effect? Can we manage that side effect? Is it tolerable? Is it something that causes damage? So yeah, that kind of thing does happen. Right. It gets a little crazy after a while. And when you say it like that, we're going to give you another medication to manage the side effects from this medication. It sounds a little bit crazy.
Right. So that's one of the reasons, I suppose, that deprescribing actually does benefit the patient, because it takes away those medications that, were only added as management of other side effects.
Right. As long as they're no longer needed. So that's one thing we want to be clear about. Hospice just doesn't come in and flat out level out your medications and take everything away. That's not to anybody's benefit, because when you do that to, say, a respiratory patient and you take their meds away from them, you're going to have a patient in crisis that you have to manage as a hospice practitioner. So that's not something we do. I think maybe when hospice started in the United States back in the 80s, under the hospice benefit, that maybe that was something that they did. Hospice teams and hospice physicians would just sort of raise all those meds, clear them out, and just start with symptom management meds. But that is not what we do now. They've never done that during my career in hospice, my 10 years. So
right. Okay. So why would you want to deprescribe medication for a hospice patient? Let's talk about some of the reasons why.
Well, the biggest reason is the medications aren't effective anymore. A patient will get to a point where medications don't work for them anymore, or they don't get any benefit from them at all.
Okay. So a prescription that they've been taking, it's no longer as effective for them, and it's not really doing them any good then. Right.
So when you think of, so let's take a really common medication, like a cholesterol medication. So certain cholesterol medications are taken and they have this future protection several years out. Well, when you have a patient with a life expectancy of 6 months or less, having to take a medication that has a benefit that lasts over 5 years, it doesn't make any sense to do that. The patient is covered for the length of the life that you're expecting. So having them take a cholesterol medication, certain cholesterol meds, is just not a good choice. It's unnecessary. And there's cost associated with that kind of thing. Most cholesterol medications are not considered related to terminal conditions. And if you're a hospice practitioner, a hospice clinician, you will understand this. We pay for things that are related to the patient's terminal diagnosis, terminal prognosis. Cholesterol medication isn't usually one that we cover, that we pay for. So it's either billed under the patient's Medicare Part D, and this is where it gets a little bit technical. We're not going to get into so much of this, or the patient and the family have to pay out of pocket. So what we typically recommend, and of course the hospice physician is in charge of deciding this, we would say we'd like to discontinue this medication. We're not going to pay for it, and here's why. We don't feel like it's beneficial. And the family can say, well, yes, we do want to continue it under the Medicare Part D, or we want to pay for it out of pocket. It's not the same thing as if it was contraindicated. That's a different situation. If a medication is harmful somehow, contraindicated, it would interact badly with other medications that the patients need, then the physician is going to discontinue those.
Sure, that makes sense. So let me ask you this. As the disease trajectory gets closer and closer to the end, so the patient is becoming unable to actually swallow, is it common then for the hospice clinician to decide, well, they've been taking this medication, but under the circumstances now, it doesn't seem necessary or doesn't seem helpful?
Right. It can be hazardous. And yes, the hospice agency does decide that. It's always in conjunction with what the patient wants and what the caregiver wants as well. So we call that pill burden. Pill burden is defined as the number of medications, the number of pills that the patient has to take or the caregiver has to administer. It becomes a burden to take that much stuff. A lot of times patients aren't eating as well. So their stomach doesn't do as well with medications that you have to take with food, things like that. The size of the pills, the textures of them, the shape, things like that, it becomes really problematic and quite traumatic for a patient to have to get those pills down and swallow those.
Yeah, it's just hard to swallow some of those things. My mother used to call it a horse pill. It's just these huge pills that are just hard to swallow, and hard to swallow for a healthy person. to say nothing of someone who's already finding it difficult to swallow anyway. So there are other methods, however, for delivering medications if a person can't swallow. And so if there is a medication that's needed, but they can't swallow, there are other ways of delivering the medications.
Oh, yeah. We're going to find a way. I mean, right. There are numerous things. So say a patient is taking some of the typical medicines that we use for symptoms like anxiety. Say they're taking Ativan or Xanax. Ativan is one of those meds. We can get it in a liquid. And it doesn't mean you have to drink 8 ounces of it. Your caregiver could even do it just under the tongue alongside, at the gum line. And the patient doesn't really have to be able to swallow. Morphine is the same way. If a patient has been taking pills or tablets for pain medications, there are liquid pain medications. There's liquid Tylenol, liquid ibuprofen. Liquids aren't the only way. There are gels that we use. We have a gel called ABH gel. A as in Ativan, B as in Benadryl, and H as in Haldol. And we use that to help manage anxiety and agitation, things like that, delirium. And we just put that on the skin. Use a gloved finger, and the patient gets the benefit from it. The caregiver wears a glove, so the caregiver doesn't get the benefit of that, except through what the patient, the patient's effects. There are suppositories that we can use. We do try to limit use of that kind of thing, but if that needs to happen, we will. There are fast dissolve tablets, melt-away tablets that are placed on the tongue, placed under the tongue. There are even medications that we use under the tongue for blood pressure, if a patient's blood pressure is out of control, but they can't swallow anymore.
Right.
And there is a point with a patient that we discontinue in agreement with the caregiver and their understanding and permission. We will discontinue all the other meds except for comfort meds. And that's frequently a discussion we have with caregivers. We go to comfort meds only. It means that the only medications that are needed at that point in the patient's trajectory are just those medications for comfort, for symptom management, to manage nausea, fever, pain, shortness of breath. I mean, we even have ways of administering medications to help with shortness of breath. A lot of our COPD patients use inhalers, but there comes a point in the disease when the patient's no longer able to interact and follow directions to be able to take a deep breath with an inhaler. Well, we can use medications. We call it an updraft dose or a nebulizer dose. So it's done with a mist and a mask, but the patient, all they have to do is breathe in and out and they get the medicine.
It sounds like that a pharmacist could be very helpful in prescribing or at least giving information and consultation on the best ways to handle some of these issues as well. Does that often happen?
Oh, yeah, absolutely. That's not something we've talked about on the podcast before, but we work very closely with pharmacists a lot. I had to call a pharmacist and say, look, I have a patient that's been getting this and this. Can you tell me what equivalent you could give me and what volume I would need to give the patient to get the same effect in a liquid? And, they figure out the dosing equivalent and how that would work from one medicine to another so the patient doesn't experience any withdrawal, and they're not overly sedated, but they get the same pain management. And then we go through the physician to say, look, this is what the pharmacist is recommending, etc. A lot of times the physicians will talk with the pharmacist as well, but the nurse does a lot of that footwork. So we definitely collaborate with pharmacists to make that happen.
So deprescribing has a lot of advantages to it. I know many times people don't think it's a good thing, but it really can be a good thing. For one thing, it takes away the number of pills that a patient would have to swallow. It also helps the caregiver because, let's face it, the caregiver is typically the one who's going to sort out the medications and place them in like a pill minder. And if you've got 15, 20 medications there that you're trying to sort out between, okay, he takes these in the morning, he takes these in the evening, he takes these in the middle of the day, and then you've got to figure it out for a week at a time. That's just complicated and can really be difficult for a caregiver to have to worry about that. So the fewer medications that a patient takes, the better it is on the patient, the better it is on the caregiver. And for that matter, it's also easier for the hospice team to manage also.
It is, to keep it clear. Well, and on top of those routine medications, a lot of our patients use what we call PRN medications, which means medications as you need it. You have fever that goes up, well, then you get some Tylenol. You have shortness of breath, well, then you get this extra treatment or this extra inhaler dose, things like that. And that's enough. That's a 24/7 job for some patients. If you think about a patient that might have seizures, things like that, it can get pretty complicated.
Definitely. So hospice really tries to do all that it can to bring a sense of simplicity to every aspect of the patient's care, which includes the medication. We're not going to discontinue medication that's necessary, but we do want to discontinue medication that's no longer beneficial, no longer effective for the patient, because it just does help the patient, the caregiver, and the team when those medications are removed.
You know, one of the reasons I think people have this perception that hospices just come in and discontinue everything is hospices have to look at the cost of medications. And I think patients and families have a concern that that's all the hospice is worried about. You're going to take away this expensive medicine that I've been taking for my heart condition, even though I'm on hospice for a cardiac diagnosis, but it's based on the fact that you don't want to pay for it. So this is what I will tell everybody, whether you're a personal caregiver, a patient, or you're a hospice professional. Of course, yes, hospices are responsible for paying attention to how much they spend on medications. They do try to be smart about how much they pay out for meds for a patient, but that is never our number one concern. The number one concern of that hospice team, your hospice team, either the one you are on and you work with or the one you receive care from, is making sure that patient has the best quality of life and is comfortable. So medications are decided on the benefit to the patient first, and then they look at the cost. If they're doing it a different way, that's not the right way to do it.
Very good advice. So we hope this has been helpful to you to understand why deprescribing can sometimes happen. It really is to the benefit of the patient and the caregiver as well.
Thanks for listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer with Jerry Finter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening, and please leave a rating or a review on Apple Podcasts.
To connect with us, you can send us an email at host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.